Good afternoon. This is Kevin Lyons. I'm the Executive Director of the Rheumatology Nurses Society, and we are live today on July 12th on Wednesday. It's a beautiful noonday. I'm broadcasting from Florida, and we have others broadcasting from the great state of New York. So I would like to welcome you to Challenging Cases in Rheumatology, part of our Rheumatology Nurse Practice initiatives. And today we have faculty Monica Ritchie and Eileen McCullough, and we're going to be talking about some unique things regarding SPA, and we have a great case study and a lot of cool things coming up today for you. This is a quick broadcast. It's about 20 minutes, so you have time to grab it and still grab some lunch. If you're watching the replay, we would just like to welcome you as well. A couple of housekeeping notes as we get started. First off, if you have not received it already, this is hot off the presses, the latest edition of the Rheumatology Nurse Practice. We're talking about new insights into the treatment of spondyloarthropathies. And this inside we have which disease states are included within the broader family of SPA, how the primary characteristics of SPA differ from those found in patients in RA. So it's a great addition. You're going to love a lot of the content in here. This is one of my personal favorite diagrams as far as going through the differentiation between SPA, ex-SPA, IBD, REA. A great addition. If you don't receive these, visit our website at rnsnurse.org. That's rnsnurse.org, and you can click on the Rheumatology Nurse Practice icon or the menu icon and sign up. These are free for you, and there's also a digital copy. Also, this and the previous two editions in 2017, you can also get continuing education credits for these, and that's all available on our website. I'd also like to remind you all, coming up here in about a month, we're almost a month away, Eileen and Monica, can you believe it? Our annual conference. We're celebrating the 10th annual conference of the Rheumatology Nurses Society as we celebrate Heroes of Caring. And we have a lot of exciting things coming up for that. The President's Dinner is going to be amazing. We're going to be celebrating some giveaways and some new publications that we just had put together just for you. So we ask you to visit again, rnsnurse.org, to sign up and learn more about the annual conference. Both Eileen and Monica are some of our faculty for our conference, along with many others. And this year, and this is one of the first announcements of the topic, we've been lately having boot camps prior to the conference. This year, the boot camp is on integrative rheumatology and the microbiome. So you definitely want to sign up and make sure you get the information for that. Last year's boot camp, just one last final thing before we get into our program, the immunology boot camp with Dr. Lenny Calabrese and Dr. Grace Wright and Elizabeth Kirchner and Iris Zink is now available on the RNS website for a CE as well. And that's all free education just for you. So without further delay, let's get into today's case study. And let me introduce Monica and Eileen. They're both on the RNS Board of Directors. Eileen heads up our research committee, and Monica heads up our advocacy committee. And we actually just got back from great time in DC with the Lupus Foundation of America. It was phenomenal. So Eileen and Monica, please take it away.
Right. So I'm going to start the case with a patient that I actually saw a few months back. This was a challenging case for me because it's the gray area in rheumatology, which is, it's in between, which is most of our patients. This is a 24-year-old male that came in presenting with at least a 2-year history of cervical pain, stiffness. On physical examination, he had severely restricted range of motion of the cervical and thoracic spine. His lumbar spine was okay, but he had that body habitus where you don't turn your neck, you turn your whole body to see or to answer if somebody's asking you something. He also reported difficulty taking a deep breath. He felt like his rib cage could not expand enough, and he felt like he was severely restricted. His symptoms actually started at age 16, which is part of the SPA presentation, and he developed bilateral hip pain and stiffness. And although he does tell us that he was, he played football and school, he never had major injuries, and they had no explanation for what was happening. There was no injuries. So the hip pain progressed, and then within about 4 years ago, so at age 20, he ended up with a hip surgery for a possible labral tear, but there was actually no labral tear when they got to the surgery itself. So he ended up having more problems than not. And then a year later, he developed left Achilles tendonitis, severe pain, swelling, again, and he was treated with NSAIDs, and nobody knew. They blame it on the surgery, but that was literally a year later after. So over the years, he'd been treated by different physicians and different providers with NSAIDs and muscle relaxers, and he reports that none of them actually worked well for him. None gave him any kind of relief. He had physical therapy on and off, and when I met him, he had seriously had physical therapy for 12 months, which resulted in no improvement. Now, this is a young man who actually had to quit school because he couldn't even sit still for enough time to read a book or look at a computer because of the severe stiffness and pain on his neck. More recently, within the last 6 months, he had developed bilateral shoulder pain as well. And he was told to have an AC joint gap, nothing on the x-rays. I reviewed the films, there was nothing there. And the orthopedist was planning surgery, but he wasn't really sure what was going on. So when we're talking about SPA, we have to make a difference between what's the mechanical back pain and what's an inflammatory back pain. In his case, when you actually get into depth of the back pain history, he had back pain at night. So at night, he will wake up with severe back pain. He had severe morning stiffness in the morning when he would take 2 or 3 hours to actually be able to move. But both of his pain and stiffness improved every time he was exercised. So during physical therapy, his pain was much better, in a few hours after. And the pain and the stiffness came when he was resting. So we have some questions here regarding this case, and I'm gonna tag on to Eileen. And Eileen, what lab test should we order, and what are the expected results?
Well, first and foremost, I would think the HLA-B27 would be ordered because 90% of patients with this disease has a positive HLA-B27. I would do C-spine and SI joint x-rays, and of course, measure for inflammation with CRP and ESR levels.
Right. Right. And do you think that this patient's back pain is more consistent with a mechanical back pain or inflammatory back pain?
I would think inflammatory.
Right. Yeah. I mean, Eileen is right on the money, with HLA-B27 being very prevalent. It's more of a in Caucasians, there is. He's report that is pain improves when exercise and that pain gets worse with non-exercise or staying stiff, like sitting for too long. That's very typical of an inflammatory back pain, and mostly reporting this pain at night, waking up with pain. Now, Eileen, this is up your alley on the research. What does research tell us about the impact of HLA positivity in patients with actual axial and spondyloarthritis?
As I was mentioning before, 90% have the positive HLA. Other than that, the research is just on what treatments can work for it.
Right.
And that's where it's a very gray area due to the type of, it depends on the type of.
Right. There are several subtypes.
Exactly.
Yeah, and the other interesting thing about HLA-B positive is that actually the people with HLA-B27 positive, only 5% of them would actually develop ankylosing spondylitis or spondylortropathy. Right. So it's not that because they have an HLA-B27 positive that you can, he's going to develop, spondylortropathy. That's not the way it works.
No, you have to play it out and see which way it develops. Exactly.
It's really, the diagnosis of spondyloarthropathy is basically a clinical diagnosis more than a laboratory base, as what all of our diseases is really based on your clinical assessment and diagnosis.
Right.
So we go forward with our case, and we order an HLA-B27, and he was negative. ESR and CRP are both mildly elevated, not extremely. And when we look at the imaging, and Eileen again was right on the money. That's usually the workup for it. Is cervical X-ray shows severe straightening of the cervical spine. It's like, I wish I had a picture to show, but I show it to other providers that work with me. I was like, what is wrong with this picture? Severe straightening. I mean, yes, it was not a little bit of a curvature there. Unfortunately for us, because it's the gray area, right? There was no sacroiliitis and no erosions, no sclerosis, nothing in the sacroiliitis that would indicate ankylosing spondylitis. So I sat on this case for a little bit, reviewing and discussing with other providers too, because that's the gray area. That's just like, it's your clinical judgment that comes into place. And I did diagnose him because of his young age, because of the presentation of bilateral hip issues, bilateral shoulders, and the Achilles tendonitis, straightening of the spine, severe decreased range of motion, and the inflammatory back pain. So I made the diagnosis of the radiographic axial SpA.
Did you think of doing MRI?
We did. We actually did. We actually had it. He had, because it's been for so many doctors until he got to me, he had MRIs of the lumbar spine. He had MRI of thoracic spine, and I sent him for an MRI actually of the cervical spine as well. There were absolutely no signs of inflammation in there.
Okay.
Yeah. So treatment, right? Because that's like, okay, so you made a diagnosis and how do we treat it? So the new recommendations that came out in 2016, mandatory NSAIDs unless the patients cannot tolerate because of GERD or any other issues with the GI system, and TNF inhibitors. So the radiographic axial SpA follows the same recommendations that we follow for radiographic axial SpA, which is TNF inhibitors. Now, when they talk about the treatment, there's no preference for one or another, except if the patient had any kind of eye inflammation, iritis, uveitis, or inflammatory bowel disease, because in that case, it would have to be either adalimumab or infliximab that would be preferred over etanercept. Okay, physical therapy continuously, we do not stop. We need to maintain a certain level of motion in the spine to avoid severe disability. In his case, even with the physical therapy, he was losing a lot of cervical motion. So he is continuing physical therapy. And it's also important that even you would think a 24-year-old, right, screen for osteoporosis is just part of the disease process. We do not recommend steroids on axial SpA at all. It's not, there is no proof that it works. There is no benefits from it. But the osteoporosis is not even related to the use of steroids. It's really related to the disease process. So what I did next, I ordered the labs to be able to start him on a TNF. So hepatitis panels were negative, quantiferon gold tests were also negative, and I started in an adalimumab 40 milligrams every 2 weeks. This was a discussion. Can you go back to the previous one? So just a minute. So adalimumab versus Remicade or infliximab is really based on, you know, your preference, the patient's preference. In this case, he didn't want to, you know, sitting on the chair for him for 3 hours would be painful.
Right.
So that's why we made the decision for him to start on the adalimumab, which, you know, he can do on his own at home, and it will not require him to sit for extended periods of time. So our discussions, Eileen. So
I think we covered the MRI already.
Right, I know, right? So do you think that should the MRI be ordered? I guess the consensus is yes, Eileen?
Well, the consensus is because it's early stage. So even though you're thinking it may not be positive. Wait, did you do an MRI?
I did.
Oh, you did. I'm sorry. But normally you would, because you want to rule out early inflammation at the early stages. But on this guy, it was negative. So in a way, that's good.
Yeah. When we look at non-radiographic SpA, we know that the radiographic progression with this particular population is actually 10 to 20%. So 80% will never develop sacroiliitis or, any kind of inflammatory changes, but they still carry the disease with them. So don't get too hang up, looking for sacroiliitis or sclerosis or any other changes, because in this particular population, the rate of radiographic progression is 10 to 20% only.
Yeah.
How would you educate this patient about his choices, as there is limited evidence to support various treatment options for non-radiographic axial SpA?
Well, since it's etanercept and all the NSAIDs really are not approved yet by the FDA for the non-radiological SpA, I would have to tell them that it's off-label, but that it has a good chance of working. The only thing is the FDA is still looking for more evidence to support that. So they would need to know that. But, and then you would just give them the same type of education as you would anyone doing a TNF inhibitor.
Right. Yeah. I mean, in our field, rheumatology, the FDA is not always at the same step as the rheumatologist.
Exactly. Europe is ahead of us. They've approved it already.
So, like ACR already came out of the recommendations that non-geographic will follow, same as geographic thing, but the FDA is still behind, right? So it issues that fight with the insurance company on our end to tell them, but this is the recommendation. So it issues a lot of paperwork on our end as well. Because of that difference between the FDA and the ACR guidelines.
They're doing more studies anyway in the non-radiographic SpA, so hopefully they'll get their answers that they're looking for shortly.
Excellent.
And I would also check PROs regularly. Do you do any of the PROs, the BASI or BASFI?
Right, you have to do it because the insurance will require you to do it.
Okay.
Yes, you have to do the inflammatory, the back pain, and the assessment of the limitations of the spine, the Schober, the
quality of life, and so forth.
Yeah, you have to do it. It's part of the documentation when you're trying to prove that the patient actually has the non-radiographic SpA and also the radiographic. How would you assess short and long-term improvement of this patient?
Well, improvement in the scales for sure. And see if, you said it was mildly elevated, the ESR and CRP, but I would still monitor it at least every 6 months to a year and see how that's doing. And and of course, how the patient feels,
And that's one of the most important things is how the patient tells they're feeling.
Right.
It's like,
what affects them the most.
Right. They will be able to tell you, in a few months, and don't expect a miracle. It's not as what I see in my own practice is that the medication takes a while to kick in that particular population. So I usually tell them, don't expect one injection to resolve everything, but, give it a good 3 months before we further discuss. But they will be able to tell you they have less stiffness. They're able to, get through the day without taking so many NSAIDs, although I rather they keep them on at least once a day. And the short and long term is exactly what Eileen said, is the scales, some laboratory, though, the CR and CRP were mildly elevated, you still have to follow, but it's definitely the patient telling you if they're feeling better.
Right.
Eileen, is there any clinical research looking at discontinuation of therapy and remission in patients with non-radiographic SpA?
Well, it's very interesting right now. Ongoing is the Re-Embark study. They're looking at Embro, and they're seeing patients, they're following patients, and when they get better, they take them off Enbrel, and they want to see within 40 weeks if there's any flares. So it's very interesting, and this will help with the FDA approval of the TNFs for this type of SPA. And it's ongoing at the moment. So I don't know what the results are.
Right.
The only sad part is there isn't that many studies right now, and most of them are in Europe instead of the US. They're even looking at NSAIDs to see if you can reduce the NSAIDs and come out with more guidance on NSAIDs being used in this type of patient population. So time will tell us, and we'll see.
Yeah, that's interesting because, you know, we know when to start. We never know when to
stop.
You know, and every patient's like, is this for life? You know, how long do I stay on the medication? And that's really one of the questions that is hard to tell because we don't have an answer for it. So I like the fact that they're actually looking at discontinuation of those medications.
And I also hope that if they do get retreated, they get relief, just like they got the first time, because maybe they won't. That's another end.
And that's the tricky part, is building up antibodies to the medications, right? Usually when we stop them in one of the anti-TNFs, we need to switch. Because there is, you know, they usually build up, your immune system is smart enough to learn to get around those medications, and they stop being effective. So that's a major, major issue because, okay, I'm in remission, but how long is that remission? And if the remission doesn't last long, what do I restart you on?
Exactly. You have limited stuff right now, but the future is promising.
There you go. I like that. All right. I guess we're done with our little discussion today.
Awesome.
Short but interesting case. You know, the one that you pull your hairs is like, is it, is it not? But it's all for the benefit of the patient.
Always. Right.
That's awesome. Well, thank you so much, Eileen, and thank you, Monica, for reviewing this case study. Again, this live session is being recorded, and so please share with your colleagues and share with other healthcare professionals, nurses, NPs, PAs, CNSs. This is valuable case study information. We have other case studies like this that are listed on the RNS website. So if you go to rnsnurse.org/RNP, and that's for Rheumatology Nurse Practice, you'll see this Google Hangout and the replays of all previous Google Hangouts, as well as the online publications of the Rheumatology Nurse Practice publication here. And again, don't forget to go on there and sign up for this. We mail out, I think it's over 6,000 of these every edition to healthcare professionals across the country. So sign up, it's free. It's part of the mission and strategic plan of the Rheumatology Nurses Society to put this type of education, quality education, in your hands for the best outcomes possible for the patients that are out there. We also want to encourage you to sign up for our conference, again, August 9th through 12th in sunny Orlando, Florida. And that's going to be at the Gaylord Palms Resort. It's going to be a phenomenal event. And we just have a lot of exciting things coming up over this next year as we go into 2018. So stay tuned. We have some unique things from RNS coming out about workforce. We've heard about the shortage of rheumatologists, and we understand that the RN and the APRN has a critical role in supporting the rheumatologist, but also providing care directly to the patient. So keep an eye out for RNS on the website and our Facebook page, on Twitter, and we'll be making some announcements like that coming up. Monica and Eileen, any closing thoughts?
No, I guess, well, always a closing thought, but I don't know. It's just like, make sure you make that difference between inflammatory back pain and mechanical back pain. It makes a huge difference. Like, this patient has seen at least another 10 physicians for a long time before they got the correct diagnosis. So it's important that when you're examining the patient, the history is what actually makes the diagnosis. Yeah, absolutely.
Yeah. Exactly.
Awesome. Well, hey, Eileen and Monica, thank you so much. Stay tuned to the RNS website and Facebook pages for the next Google Hangout. And for today, we'd like to thank you for joining us. And we're signing off. Have a phenomenal day, and hopefully we'll see you in August in Orlando at the annual conference. Thank you so much.